Hi, this is assessment and management of patients with hypertension. Not as in-depth or long as the other ones, I don't think. Here's your objectives. Be able to review and discuss them and make sure you know the terminology of the chapter. Hypertension. The definition of hypertension, or the guidelines, I guess, for hypertension have changed over the last few years. Systolic blood pressure of 140 millimeters of mercury or higher, or a diastolic blood pressure of 90 millimeters of mercury or higher. So that is high blood pressure. You can see the table in your book, which compares the old guidelines with the new guidelines. Patients are typically diagnosed by their practitioner or prescriber after multiple recordings of blood pressure measurements that are elevated at separate visits. Hypertension can lead to a gajillion problems with the heart and circulation. Heart attacks, heart failure, strokes, renal disease. So we got to get the blood pressure controlled well in order to maintain our patient's level of wellness. So here is a copy of normal. Here's elevated. Here's high. But this is stage 1. This is stage 2. So I guess that 140 over 90 is not right. That's stage 2 hypertension. This is stage 1. So I know some of you, when we were doing our blood pressures and such, you guys had some pretty high blood pressure readings. So I hope that that made you stop and think about what you need to do to change your modifiable risk factors and make an appointment with your doctor to discuss. So we do call hypertension the silent killer. Why is that? Because it's pretty prevalent, but most of the time it is no symptoms. So what causes it? A lot of people, they'll say there's an unidentifiable cause. They can't pinpoint it. There's a lot of things that we do, especially as Americans, that can cause our blood pressure to be high. So 90 to 95% of patients have primary hypertension. Secondary hypertension is the other 5 to 10%, and it's caused by renal disease, sleep apnea, or it's pregnancy related. 33% of the adult population in the U.S. has hypertension, and 46% do not have it under control. So that's a lot of people not having it under control. The highest prevalence of high blood pressure is African Americans. So our symptoms are vague, or we don't have signs and symptoms. We might have a headache, or every so often somebody might have a nosebleed, but usually nothing. Here's what they think the risk factors are, well, we know they are, for developing high blood pressure. Smoking, family history, sedentary lifestyle, being overweight, having a poor diet, not managing stress. Sometimes it doesn't have any identifiable reason at all, like you do everything right and you still have it. So it's very important to get your annual screenings. Make sure you get your blood pressure evaluated at least once a year, because early diagnosis and treatment can stop further damage to your blood vessels. And then some other, other different underlying conditions can cause secondary hypertension. I already talked about that, but I didn't tell you all of them. So here you go. Kidney disease, adrenal disease, which is going to be different hormones that are going to drive that up. Hyperparathyroidism, thyroid disease, tightening of the aorta, obstructive sleep apnea. And the side effects of some medications can also contribute to secondary hypertension, including birth control pills, NSAIDs, or nonsteroidal anti-inflammatory medications like ibuprofen and aspirin. Stimulants, we talked about stimulants causing increased heart rate. Some antidepressants, decongestants for sure can raise your blood pressure, and diet pills, again, stimulant medication probably. Usually no symptoms other than your blood pressure reading, so it's important to have it screened. But other symptoms that can show that there's some organ damage, and by the time these happen, it's kind of late. Retinal or other eye changes, renal damage, myocardial infarction, cardiac hypertrophy, and stroke. Those are all things that are pretty big risk factors if you have undiagnosed or untreated or unmanaged hypertension. There's so much uncertainty about the pathophysiology of hypertension. A small number of patients, between 2 and 5%, have an underlying renal or adrenal disease as the cause of their raised blood pressure. In the remainder, no clear single identifiable cause is found, and their condition is labeled as essential hypertension. A number of physiological mechanisms are involved in the maintenance of normal blood pressure, and their derangement may play a part in the development of essential hypertension. It is probable that a great many interrelated factors contribute to the raised blood pressure in hypertensive patients. Among the factors that have been intensively studied are salt intake, obesity, insulin resistance, stress, genetic alteration, renin-angiotensin system, fewer nephrons available in the kidneys, and the sympathetic nervous system. In the past few years, other factors have been evaluated, including genetics, endothelial dysfunction, low birth weight, and intrauterine nutrition, neurovascular anomalies. That's a lot of big terms. I think, too, that's not listed, but if you think about how, as we age, our blood vessels become less pliant, so they get stiffer, our muscles get a little bit older. I had another thought about something when I was reading off these factors: salt, obesity, insulin, stress, genetic. Somewhere in there, I thought, oh, and this, but it's gone. So maybe during lecture. Measuring blood pressure. We already know how to do it. We totally do. 2 blood pressure readings on average to diagnose high blood pressure. Sit quietly with arm at level of the heart. One thing this doesn't say, but I want to add, is that you also don't want your legs crossed. Some alternative manifestations of high blood pressure are masked hypertension, and that's when the patient's being treated for hypertension, but they have a normal blood pressure in the clinic or the doctor's office. But then they will have an elevated one at home, which is weird because I feel like that is not the typical thing. Because typically we see white coat syndrome, which is when you're nervous because you're at the doctor's office and your blood pressure goes higher. But it's fine at home. So here's some abnormal physical examination findings. We've talked about it a little bit. Absent or weak pulses. What does that indicate? Poor peripheral vascular system. So damage to the vascular system. Additional cardiac sounds. So you got too much fluid in there, or your valves are not working right. Something's happening in there. Or you've got electrical issue. Retinal hemorrhages. So your blood vessels, you're going to see microvascular damage, I feel like, first, before in the big vessels, because small is going to be damaged first. So it makes sense that those tiny microvascular areas behind the eyes will have hemorrhages, and that can affect your vision. Distended jugular veins, which are the veins that run along the side of the neck. You can see them pulsing from across the room sometimes if your patient is sitting up at like a 45-degree angle. And then renal artery bruit. Listening to the sounds in the belly and near the, you can hear these extra sounds, and it's like a buoy. If you have ever felt, I don't know, it's just a very loud pulsation sound. And it's because the pressure is so high. There's your major risk factors. This microalbuminuria, remember levels of albumin, and that's on your list of labs to know. I don't think it's worded that way. GFR is glomerular filtration rate less than 60. So that's showing that perhaps your kidneys are starting to slow down a bit. So these are all the things that can, dyslipidemia, that's high cholesterol. Diabetes, all the rest I feel like are pretty self-explanatory. Physical assessment, we're going to look at the eyes. We're going to look at labs. We're going to look at the urine, because I'm going to look and see if we have kidney damage. Blood chemistry panel, also kidneys. Electrolytes, I want to know all that. And then an EKG or ECG, which is going to tell me the rhythm of the heart. Medical management, keep that blood pressure less than 130/80. If you need to lose weight, lose weight. The DASH diet, which is a decreased sodium diet. Regular physical activity, reduced alcohol consumption. Some people will, some doctors may wait a little bit before they put patients on a blood pressure med. Others will put you on it right away, depending on how high it is, or how long it'll take you to change lifestyle factors. But a little bit of both can go a long way. Here's your medical management. Diuretics, which we've talked about, beta blockers, alpha-1 blockers, alpha-beta blockers, vasodilators, ACE inhibitors, ARBs, calcium channel blockers. Dihydropyridines and direct renin inhibitors. The goal of medication is to decrease the peripheral resistance or constriction in the blood vessels. The heart is working really hard against those high blood pressures just to pump blood around this patient's body. So helping the heart not contract so forcefully will decrease that work. Remember, this patient does not have heart failure yet. There are many medications a provider will use to decrease the patient's blood pressure. They are listed here. Pause the video and take some detailed notes on the different medications that are used. We will discuss them in detail during class. Medication treatment. These are typical medication treatments that we will give to people, depending on where they fall in age and in stage for their hypertension. And they might have to take multiples, and we may have to change them around sometimes. Sometimes we will start them out and it'll be too high, and they'll be dizzy. So we have to do a lot of education. We also want to look for history, asking them what's been happening in your life, what's your history on how you eat, your exercise, all the things we've talked about in other videos. But also ask them about specific symptoms to see if they have organ damage. So do they have, what's angina? A lot of times it is intermittent chest pain. And maybe it is stable. What is stable angina? If you don't remember, go back and look. You need to know the difference. What is unstable angina? And do they have shortness of breath? Altered speech, like maybe they have symptoms of a stroke, or they've had a TIA, which is a stroke that resolves within 24 hours. So those are all signs that you might have uncontrolled hypertension. Nosebleeds, there's my nosebleeds thing I said earlier. Headaches, dizziness, balance problems, nocturia. Nocturia is frequent urination at night. Cardiovascular assessment. Listen to that apical and those peripheral pulses. And get your background history on your patient. Here's some different problems that could occur in addition to or because of the hypertension. And these are a few of the many goals based on your assessment that can be used for a patient diagnosed with hypertension or someone who's had it for years. Pause the video and read through them and see if you can think of some more. And there's some diagnostic statements, interventions. Big things with these types of things, these are preventative if you catch them early enough. But keep in mind, anybody who has hypertension, they may not have had any symptoms. Now you're telling them you have this disease or this silent killer thing going on inside you. We need to have you change all these things about your lifestyle. And in addition, take some medication to lower your blood pressure. So they need to really understand what's in it for them to buy into the fact that they need to make changes, I feel. So blood pressure medications are the least, I'm not going to say this right. People don't take them how they're supposed to. So they don't take them because they don't like the side effects. So I know people in my family quit taking them because they felt bloated and they had GI upset. I'm like, all right, well, you could have a stroke, but we don't want your tummy to hurt. I'm so rude. Sorry. Did I say that out loud? No, I just encourage that family member to go back to their provider because there's other options. There are so many medications. But that family member did not want to do that because they don't have awesome insurance and they didn't want to pay for another visit. So instead, they'll wait until they have a massive heart attack or a stroke because they aren't controlling their blood pressure. So a lot of education and teaching them how to monitor their blood pressure. Do they have modifiable risk factors they could be working on? Everybody does, I feel like. Evaluations and outcomes. How are their labs looking? How are your interventions? Were they successful? There's some more. Gerontological. Nope. Gerontologic. Older person considerations. They may have a hard time remembering to take their meds, especially if they have to take them multiple times a day. If the meds are expensive, that could be a challenge if they're on fixed income. If you can simplify the medication and make it less expensive, that will be super helpful for probably a lot of people. Monotherapy is new. It's sort of new. It's where we're combining medications that are diuretics and blood pressure meds, and they're in one pill. And so they only have to take it maybe once or twice a day instead of taking 2 different pills 2 times a day. So another thing is with your older patients, is if they're taking a diuretic, you want to make sure to educate them on the risk for falls if they are frail or if they have a previous history of falls. They may need to use a urinal if it's a gentleman, and maybe if it's a female, you'll want to have a bedside commode, or you want to take that patient to the restroom every hour or offer it every hour. My phone is blowing up all of a sudden. I probably should see who's calling me. I wonder if we're almost done. We are not. Hypertensive crisis. That's a blood pressure above 180 over 120. And it has to be lowered immediately to prevent further damage to organs. It's also a huge indicator that you could have a stroke any second now. You're probably damaging most of your organs, but your kidneys and your brain are not liking your blood pressure there. So we want to reduce that blood pressure but we don't want to take it down by more than 25% in the first hour. Then we bring it down a little bit more, gradual reduction. And there are some exceptions. If someone has an ischemic stroke and aortic dissection, so hypertensive emergency, they're most likely going to go to ICU from the ER. This is because for some patients, they have to have a special IV drip medication. We'll learn more about those in Block 4, not now. Also, there's hydralazine, which can be ordered and given every 6 hours or so, PRN. We've talked about that. Very frequent blood pressure monitoring and assessment. So I want to go back to what it says. Exceptions are ischemic stroke and aortic dissection. Ischemic stroke is where they have a clot blocking the flow in the brain. We want to keep their blood pressure elevated if that is the case, because the elevated blood pressure is the only thing that is probably perfusing their brain at this point. If we bring down the blood pressure, blood is not going to be able to get beyond whatever is including that area. Higher blood pressure is probably getting a little bit of blood flow beyond it. So I think they let it be a little bit higher. They will not maybe keep it, like if it's over 200 systolic, they're not going to keep it there. But they're going to keep it high for a while until that ischemic stroke is resolved. Aortic dissection, on the other hand, they're going to bring it down right now because your aorta is spurting out and you're going to die. I'm pretty sure that's the difference. But since I don't have any talking points and I'm doing this from what I think and I remember, we can look into that when we are in class. Hypertensive urgency. We want to normalize blood pressure within 24 to 48 hours, so we're going to give a beta blocker like labetalol or metoprolol, an angiotensin-converting enzyme inhibitor like captopril or lisinopril, an alpha-2 agonist like clonidine. They got to be closely monitored, and we got them on a cardiac monitor. So we're going to be checking their blood pressure and their cardiovascular status, doing listening to the heart, listening to the lungs, checking the pulses, checking the vision, all of it. And I think we're done. We are. See, 22 minutes. I feel like this is my last recording of the day. So the rest will have to wait till this weekend.